sclerosis and add some meds, and then we'll be done. Okay. So, you remember talking about spinal cord injuries in level 2. We talked about just what you're going to do initially, and level of injury, things like that. We'll review those. But remember our mechanisms of injury with the hyperflexion and then the hyperextension. Compression. Who has these compression fractures? Older people with falls, and then who do we see with these compression fractures?
Baby.
People who are jumped over and drunk or did something stupid, who have the ones in their cervical spine, because usually it's a dive into shallow water, or sometimes it can be a car accident. I'm just going to tell you, 99% of the time there's alcohol involved in those decisions.
I had a friend who jumped off a bunk bed.
Jumped off a bunk bed?
Yeah.
Why would you jump head first?
I don't know, you're a kid.
So, there are the people who, I'm just going to tell you, when I used to work for the Air Force, all the incidents that occurred that we had to go to these mandatory in-services about, there was always alcohol involved that caused the problem. You know, whether it had something to do with sexual assault or drunk accidents, there was always alcohol involved. So this is, you're going to see this in your population that 15 to 20 something who make bad decisions and are in car wrecks or do things that are dumb. You have the same mechanism of injury here that you had for head injuries with lacerations and penetration wounds. So bullets, knives, things like that. That didn't change from last time. Secondary injuries. We talked about this last time real briefly, and we're just going to review it. We have a change in blood flow where we have some problem with the injury itself. There's a release of neurotransmitters, which causes our immune system to start working. What happens when your immune system starts working? You have inflammation and edema right there at the site because it's attacking anything that's foreign. And then you have some nerve cell damage, which kills the cells in the spinal cord, and you have scarring. So that's where your permanent injuries come in. So is my injury that I have at the beginning necessarily my deficits I'm going to have in 2 months? No. Once the swelling goes down and the initial injury is over, if I can prevent secondary injuries, I might have some function back or have some improvement. We talked about this last time, same exact picture. Remember our level of injuries, the higher up the injury occurs, the more deficit my patient's going to have. Does that make sense? Mm-hmm. Which one of these patients could learn to walk using assistive devices? L1. Yeah, the L1 injury or below the waist. Which one's going to need me to feed them?
Four.
Sometimes C6 patients can feed themselves because they have big gross motor skills. They just don't have fine motor skills. It just depends on exactly where the injury is and how severe it is. That's why they can play video games, you know, because they have good gross motor skills. Who's going to need my help with respiratory problems? C4 is probably going to have some sort of artificial respiratory device, ventilator, trach eventually. This one might need my assistance if they have any kind of pulmonary problems and they need assistance with coughing. Because remember we talked about the quad cough, where it's almost like the Heimlich maneuver where you have to breathe deep and cough and you're putting pressure so they can cough up the phlegm and stuff. Who might be able to have bowel and bladder control? Okay, remember what we talked about when we talked about bowel control? You can put them on a regimen and they can almost all regain control of their bowels to some point. Mm-hmm. This one, he's going to be the one that requires the most care, but with a bowel regimen, they'll go at a certain time. They might not be able to get on the toilet, but it's pretty predictable. So I have my bowel movement in the morning, and I can be in my wheelchair the rest of the day and move around. Who might have to in and out cath themselves. Yeah, T6 or below, they might have to in and out cath themselves. So just think about your level of injury and what my patient can do if they have an injury at that level of the spine, okay? Because it makes a difference. So, initially, what am I thinking about when I have a spinal cord patient? ABCs initially. What's the next thing I want to think about? Yeah, I want to stabilize that spine. Because if I don't stabilize the spine on my way from A to B, until I know if there's a fracture or a spinal cord injury, it could get worse. I could have secondary injuries. Do I want to assess their Glasgow Coma Scale?
Yes.
I do. Did they have a point in time where they had a loss of consciousness? Because if I have a spinal cord injury, the chance of having a head injury along with it, pretty significant. So I want to make sure that I check the Glasgow Coma Scale. But this, I am preventing secondary injuries, so that's very important. We talked about all these devices last time. The Miami J collar and the Philadelphia collar, and this thoracic lumbar sacral brace. Did we talk about the halo fixator at all? Okay, the halo fixator is for cervical fractures. How does it work?
It keeps the head from moving at all.
It keeps the head from moving at all. It puts a little traction on the neck and keeps it aligned. This is what I want you to know. There's a chart in your book about this halo. I want you to look at that chart. Pins, it's screwed directly into the client's cranium. So I'm looking for signs and symptoms of infection. I'm going to do pin care on that, which is usually prescribed by the doctor, but it's usually half-strength peroxide and then some sort of bacitracin around those pins. Who tightens the pins or fixes them? The doctor. I leave the little Allen wrench taped on the wall above the client's head of the bed, but the only person who adjusts those screws is the doctor. What about that lamb's skin stuff?
Make sure they're not skin.
Okay, I'm gonna look for skin integrity underneath the armpits and places like that. Does the t-shirt go over or under that? Over. So I want something that I'm gonna actually have to cut the neck out of and put it over. The sheepskin goes against the patient. Can it get stinky?
Yes.
Yes. It snaps on and off. You can take it on and off without, and put the new one underneath it and wash it. Can my patient have a pillow?
It's gonna be
It says that they can, I've never seen anybody do it, but they can have a small pillow that just supports their head underneath there. Here's another thing you need to think about. Do you move your patient with the halo?
No.
No. Does it happen?
Yes.
Yes, or we'll be talking about it. It's like that sticker, you know, don't do this. Yes, a patient one time said, well, I don't know why you're having so much trouble moving me in bed. The text today just grabbed a hold of this and pulled it over down. So they got underneath the arm and held the halo and pulled them up in the bed. You don't move your patient by the halo. Okay? Hey, I'm just saying, it's in your book. It must have happened before. What about if a patient lives where it's cold? Anything I need to think about with those pins? They are going to hurt. So if you live somewhere where it's cold, they need to wrap those pins before they go outside so that the cold's not transferred directly in. Huh? 6 to 8 weeks.
Then how do you sleep?
Sitting up.
You can, on your back or on your side.
So is it flat on the back side?
Your head's still suspended. That's why you can put that small pillow in there if you want to support your head. It's supported by the screws.
Your shoulders.
Yeah. Yeah, you might put your head up just a little bit so that your head of the bed is up a little bit. We had a little patient at Biloxi Regional one time who unscrewed her screws. She had called all night long on the light saying how much this halo hurt. And finally, when we called the doctor back like the 6th time, he's like, I don't know why you're calling me again. I already told you there's nothing I can do about this. We're like, well, you need to come in now because she's unscrewed the thing from her head. And what happened was we went in the door and she turned her head like this and we're like, oh, she shouldn't be able to turn her head like that. she had managed to unscrew all the screws and had the thing off. She was determined, very determined. What about eating? Anything I need to think about if my patient's eating?
Small bites, use a straw.
Okay, small bites. Okay, what? They need to use a straw. They can't tip their head back. I mean, I need to make it look funny, but it's common sense. They need to drink with a straw because they can't move their head back like that. What about driving? I'm discharging them home from the hospital. Okay, no driving. You don't? We had a patient who we discharged from the hospital, a young guy, and we told him, no driving, blah, blah, blah. Next day, I see him on the beach riding his bicycle. So, we weren't very clear with our, what you can drive, He was young and healthy. How much does that halo weigh?
A lot.
Weighs about 22 pounds. So, my guy who was riding the bike was pretty young and healthy. He just made a bad choice.
Mm-hmm.
No, I had to do some work.
You should have.
I should have yelled at him, but I
Did
didn't.
you give him a ride?
No, I didn't give him a ride. I didn't have anywhere to put his bike. But he was young and healthy, so he didn't have any trouble holding that halo up. But think about this if you have it on a patient who's older, a frail little lady. They're very top heavy, so they have a bigger increase in risk of
Probably
fall.
sedentary a lot too.
He's not my patient. I guess. It's almost riding his bike. He was discharged. I no longer had his record on his bike. So I want you to go in the book under spinal cord injury and look at the precautions and the patient teaching for a client with a halo, okay? We talked about spinal shock. What is spinal shock? Every patient who has a spinal cord injury experiences spinal shock.
It's temporary.
Okay, temporary loss of what?
Sensory, reflex.
Everything. How do I know when it's resolved? Well, I might never be able to move my leg again. Well, I severed my spinal cord. Am I going to have sensation in my toes?
Nope.
No.
When all their vital signs go back to normal,
Okay, it can take several weeks. What did you say about vital signs?
they return back to their room.
Okay. Maybe.
Like their blood pressure go up or something.
Okay, they're going to have a low blood pressure. Their blood pressure may go up a little bit. But how do I know when spinal shock is completely resolved?
Reflexes come back.
Reflexes return. That's all I know. I might not have movement and sensation, but because reflexes don't have to travel to the brain and back, they just make a loop through the spinal column, I'm going to have reflexes return, especially patellar reflexes. So spinal shock is temporary loss of sensation, motor function, and reflexes. It lasts 24 to 48 hours. I'm going to say that, but it can last longer than that. But usually it's resolved within about 48 hours. My patient's going to have a low blood pressure, a little bit drop in their pulse rate because there's a little bit of break in there between the nerve impulses and the cardiac function, and it is resolved when I have a return of my reflexes. I might not have motor function, but I will have reflexes. Okay? So, what do you want to do to care for this guy? What kind of things do you think you want to think about? Safety. Okay. Pulses. Okay.
Skin
What kind of
integrity.
education?
You want to tell them it's temporary. Scan right now.
How do I tell them? This is temporary. I mean, Christopher Reeves had money and this wasn't temporary.
Spinal shock.
Okay, well, we're talking about him now. He's ready to go home. It's not temporary. So someone said skin integrity. What do I want to teach him about skin integrity?
Like this tailbone area.
Okay, turn or get someone to help you. If you can't turn, Can my patient who has an L1 fracture turn?
Yes.
Yes, he can help with turning, he can use the trapeze. If he's in a chair, what can he do?
Use his arms.
Push himself up, they're called wheelchair push-ups. Lift himself up with his arms and scoot his bottom around. Is that a natural thing for someone to do?
Yeah.
It is for us, because we can feel. When I've sat too long, I know that I need to move. So you have to program him, it's like you train a puppy to go to the back door to go outside. Every hour, you need to lift up and shift your weight in that wheelchair.
Here's a treat.
Skin integrity. Do I need to teach his family anything about it?
Yeah.
If they can't turn themselves, they're gonna have to help turn.
Right. Pad places like heels and bony prominences, because
Avoid like hot substances, hot and cold things, they can't feel good.
They're gonna need psychosocial work.
they can't feel the temperature. So yes, I wanna make sure that I'm not bathing them with water that's too hot or things like that. What did you just say? Okay, what can occupational therapy do for this guy? Assistive devices. If he needs a spoon that has the bigger handle that he can grab a hold of, or splints so that he doesn't get contractures of his hands and feet, they can help him with that. Okay, they may have to do a home health assessment. Just getting in his house might be a problem. Because if you don't have a handicapped way to get in your house, like I know every door in my house has at least a 4-inch step. So if I had somebody who came with a wheelchair, I would have to have a ramp built for them to come in and out of the house. What about getting a shower? Would that be an issue?
Swinging doors.
Okay, he's talking about some depression. Do you think this person has depression? Yeah, because it's a loss of a lifestyle. If this man in this fuzzy picture was the primary provider in his family, and now he can't work, is that a stressful situation? What about urinary tract infections? Is that a problem? Yes. When you can't feel it, if you had a urinary tract infection, you know it's painful when you go to the bathroom. What are you going to teach him? Odor, color, things to look for. If he has to in and out cath himself, who's going to teach him how to do that? Yeah, you are. Is that sterile or not sterile?
Not at home, it's not. Clean.
Okay, it's sterile for us if we're doing it in a hospital. He's going home. Is that a sterile
Clean
procedure? It's a clean procedure. It's aseptic. They actually wash the catheters and reuse them. Huh?
At
He goes
home.
home. It's not sterile when he goes home. Most people who have a spinal cord injury actually have colonized bacteria in their bladder, and so they always have some sort of a urinary tract infection. But he needs to know, change in smell, change in the look of it. That's an indicator that he needs to go to the doctor. What about respiratory problems? Yeah, the higher up it is, the more risk they are for respiratory problems. Can they use an incentive spirometer?
Yes.
How am I gonna use it?
Someone's gonna hold it.
Yeah, someone's gonna teach me how to use it at Florida Point. Because I love getting a report when they say, he has an incentive spirometer, and then you walk in and it's in the plastic bag on a Winston still. Oh, thanks for taking it in the room, you know? What else do you think you wanna do to take care of this guy? What kind of special diet? You're just making stuff up. Okay, I will say this about a special diet. Let me say this about a special diet. Are there things that he could do that would help with wound healing, things like that? High protein diet. Do I really want a high calorie? No. Not particularly.
PT would work on him for range, like, to help, especially if he has the lower, he could build up his arms, keep his arm strength to help.
Correct. I mean, if he's able to transfer himself from a bed to a wheelchair and get around in a wheelchair, upper body strength training is important so that he can take care of himself. So when you're reading through your books, when you get to the part about the care I want you to look at all those things that it talks about with preventing complications for the spinal cord injury patient. We hit on most of them. Well, I just want you to read through those and make sure you look at them. Here's our medicine that you have to talk about because it's on your syllabus. Central acting muscle relaxers. What's the other name for this one? Tenazidine. Xanaflex. It was a medication that was originally made for spinal cord injury patients, and it relaxes the spinal cord muscles and gives them some relief. Baclofen is the other one. It can be given as a pill, or it can be given through a baclofen pump that's directly into the spinal column. Let me ask you a question. If I have this catheter inserted into my spinal column, and this pump's implanted under the skin right here in the front, what kind of problems could that person have? Infection. And if I get an infection in my spinal column, it can go to the brain. I can get meningitis. Yes. But those are your two muscle relaxants. So what kind of safety things do I need to think about? Okay, no alcohol. Alcohol potentiates the medication. Safety. So I give my patient who's in the hospital, and we're just going to say he just has a back injury. I give him some Xanaflex, and I say, I'll be back to check on you in a little bit. Anything I might want to consider in the hospital? Yeah, all that junk all over the place. His SCDs, the IV pole, he might have a polarized machine for something. Might need to make sure he has a call light and a safe path to the bathroom. If I'm sending them home on these medications, what about driving? Right, this is one of those medications that don't drive because you know how this medication affects you. It does make, I can take these muscle relaxers, and as long as I keep going, I'm fine. But if I sit down and relax, I'm zonked. So you have to know how the medicine's going to affect you before you go out and do something with it. They do use Flexeril, but it's not, I don't think it's been mentioned in your book. I think the ones that were mentioned in your book. This is the new thing we're adding for spinal cord injuries, autonomic dysreflexia. There's three things you're going to have to know eventually before you graduate. Spinal shock, you should have learned that in level 2. Autonomic dysreflexia, and then in level 4 we're going to talk about neurogenic shock. But autonomic dysreflexia is a problem that people with spinal cord injuries have. It happens in people who have injuries at T6 or below, okay? Or above, I'm sorry. If you have a painful stimuli below this level of injury, there's no connection here. So I have this painful stimuli that I can't feel, and I can't tell you what it is, and my brain doesn't know it's my ingrown toenail, but I'm still reacting to this painful stimuli. And the way they react is above the level of injury, they're going to be flushed, they're going to complain of a headache, they're going to have high blood pressure, a lot of them have runny noses, which I don't understand that, I don't know why, but they do say that, my sinuses are bothering me. They're going to have a slow heart rate, they're going to be profusely sweating, okay? And they're going to be telling you, something's wrong, I don't feel right. But they can't tell you what it is. Below the level of injury, you're going to see cool, pale skin with very little sweating because there's no connection between the brain and the bottom half. This is usually caused, the number one cause is a full bladder. So, if your patient has a Foley catheter, what kind of things do you need to think about? Where is it hanging? Where is it hanging on the bed? Is it someone leave it up on the side rail? Is it hanging down lower than the client's bladder? Is it draining? Make sure there's no twists or kinks in it. Is it still clamped? Did I collect a urine specimen and forget to unclamp it? Yes, that's a big one. The second biggest cause is a fecal impaction. So if you can't resolve it with the bladder, you're going to check and make sure your patient's had a bowel movement. Let me go back to the bladder real quick. Let's say your patient in and out caths himself. What's a good question to ask them?
When was the last time you got it yourself?
When was the last time you did it? Because they recommended they do it every 4 hours. So, you're out at the Mardi Gras, you haven't thought about it at all, and it's been 8 or 9 hours. Did that cause a problem? So, you have to think about those things, whether it's in and out cath, or they had a Foley catheter. When was the last time they took care of it? Fecal impaction, a pressure ulcer. Just sitting in the same position for a long period of time without moving, where we would know to move because we feel it, they don't. That can be the stimulus that makes them uncomfortable enough to have this reaction. Restrictive clothing. Let's talk about that. If they're in the hospital, what kind of restricted clothing would you see in the hospital? The SCDs possibly, TED hose for sure. So if your patient has TED hose on, you want to take them off. When you put TED hose on, how many times have you ever gone in a patient's room and they're all wrinkled up around their ankle or behind their knee,
All
and
the
rolled
time.
down? Every single time, exactly. So if it's on me and it's uncomfortable, I'm gonna know to reposition it and move it around. This patient's not gonna know. So this is what you're gonna do when a patient calls on the light and you go in and find him looking like this. High blood pressure, he's flushed, he's telling you something's wrong. The first thing you're gonna do is make sure that your patient is safe, okay? And you're gonna get him in a sitting position. So why do I wanna put him in a sitting position? Even if he's in the bed, I wanna put the head of the bed up. Because what I'm hoping is that just putting his head up, I'm gonna have some orthostatic hypotension and get his blood pressure down a little bit, okay? Then I'm gonna get a set of vital signs, because I wanna know what his blood pressure and pulse is. Then, what am I gonna do? I'm gonna go call the doctor? No, I'm not gonna go call the doctor, because there's other things that I can do. Well, I'm gonna do his bladder first. The first thing I'm gonna check is his bladder. Is he distended? If he in and out casts himself? Does he have a Foley? I'm gonna make sure my Foley's not kinked off or draining or hanging higher than his bladder. And then I'm gonna check my STDs, make sure that nothing's constricting him. Think about this. Have you ever put your tennis shoe on and then in an hour you go like, geez, this shoe hurts my foot, it's tied so tight.
Yep.
Yes. Well, he can't tell you that. So I want to start taking stuff off if he has anything restrictive on. Then I want to call the doctor. Because if you call the doctor before you do anything, and you call the doctor, your conversation's going to go like this. Hey, Dr. Smith, this is Marcy. I'm calling to let you know that I think that the patient in 623 is having autonomic dysflexia. Oh, no, I didn't get a blood pressure. No, I didn't check the bladder. Why are you calling me? You know what I'm saying? Because the first thing he's gonna say is, what have you done to try to relieve the symptoms? You know? So you wanna make sure you're trying to do some things first. What can happen if I don't get his blood pressure under control?
You have a stroke.
He can have a stroke. A stroke is one of the big things. They can have bleeding in their eyes because they have hemorrhagic of the vessels in the eye. But a stroke is the big thing. So that is the main reason you want to treat this as quick as possible. And I'm telling you, they'll all tell you something's wrong, but I don't know what. Because from the injury up, they have that panic, but from the injury down, they can't feel anything. So it's up to you to go in there and try to figure out what's going on with the patient. After everything's resolved, what do you need to do? Document. Educate. I need to educate my patient. You can't go for 10 hours without in and out capping yourself. You have to stick to the every 4-hour schedule. You know, when you're putting your son's tennis shoes on, you can't tie them so tight that, you know, without checking. You have to educate the family, because preventing this from happening is the biggest thing that you want the outcome of this. No harm to my patient, of course. But my biggest thing is I don't want this to recur. So patient teaching is the biggest thing that you have here. So there's your picture that kind of sums it all up. I think in your book there's like 1 or 2 whole paragraphs about it. But you're gonna look for a cause, make sure your patient's safe, get your vital signs, and then look for a cause and try to treat the cause, and then call the doctor. And I know there's a box, and I know the first thing in the box says call the doctor. I'm telling you that's the wrong answer, okay? It's not the right answer. Don't call the doctor first so you do something.
So if you assess the scan for all that before you call it too, or
What am I assessing the skin for?
the pressure ulcers and stuff?
Well, yeah, but usually if I just move them around, if it is that, if it's because they've been sitting in the same position a long time, as soon as you move them and they're released, the pressure's released, they're gonna have a decrease in symptoms. Even if I fix the whole problem, do I wanna let the doctor know though?
Yes.
Yeah, I had an episode with him, this is what happened, this is what I did, and it resolved. But I wanna let the doctor know that it did occur. Someone texted me about these spinal cord tumors. There is exactly 2 slides about these in here, because this is what I want you to know about them. It depends on where the tumor occurs in the spine, what kind of symptoms I'm gonna have. So if my tumor is occurring in the cervical spine, I'm gonna have the same kind of symptoms that I would have if I had a cervical injury. If it's occurring in the lumbar spine, I'm gonna have some issues with walking, maybe numbness and tingling in my legs. All I want you to recognize is that wherever the tumor is growing is where my deficit's gonna be. And is the tumor growing quickly or slowly? If it's growing slowly, I'm gonna have gradual onset of symptoms. If the tumor is a fast-growing tumor, my symptoms are gonna happen quickly. Most of these occur in the thoracic spine, and most of them are metastasized from somewhere else in the body. Okay? The second slide, my primary goal is to make the patient as comfortable as possible, and so surgery is the main source of treatment to remove as much tumor as possible. However, if you go in there and start digging around in their spinal column, is there a chance that you can cause problems?
Yes.
Yeah, so they're very cautious with that. They try to get as much as possible without disrupting the actual spinal cord.
And then do radiation before the surgery?
It depends on how big it is. If it's very large, yes, I'll try to shrink it first. The surgery is the main treatment. Decompression surgery is done just to go in there and open up the space and relieve symptoms. It's when the tumor's too big. And then radiation is the second choice. Why is chemotherapy not up there? It's more localized, and the blood-brain barrier doesn't let the chemotherapy get into the cerebral spinal space to treat the tumor, so that's why. I don't want you to get lost in that, I just want you to know. If the question says, your patient has a spinal tumor at L4, you need to know what your deficits are gonna be. If your patient has a spinal cord tumor at C7, what are my deficits there? Don't get lost in that. I think they actually took spinal cord tumors out of vision completely, but it's still in Brazil's. So that's why we're talking about it.
Where you said thoracic spine?
Most common in the thoracic spine. And it's most common to be metastasized from somewhere. It's rare that you have a spinal tumor that actually arises from the spinal cord or the bones in the spine. It's usually metastasized. Okay, let's talk about multiple sclerosis real quick. This is the only thing new that we're talking about for multiple sclerosis. There's a little case study in here. Y'all can read it if you want to. I want to get to the medicines. Remember, multiple sclerosis is this demyelinization right here, where the body attacks itself and eats the myelin sheath. And then for a little while, the myelin sheath can regenerate itself. That's why this is the way your patient looks at the beginning. They have an episode of exacerbation and they go right back to normal. Then they have another one and they go back to normal. But eventually, usually at the 10-year point, they don't go back to their baseline anymore. It progresses. The bottom one is very rare. It usually occurs in male patients when they're in their 40s to 50s, and it's very quick progressing, and you can see it never goes back to the baseline. So the ones that we're concerned about is this patient right here who lives with multiple sclerosis every single day.
The top two.
The top two. And this is initially, and then this usually occurs after about 10 years with the disease. So it's a chronic progressive disease, which means it's never gonna go away. And I'm gonna have periods of exacerbation and periods of remission. It's greater in women than men, and it usually occurs, the initial onset is between 20 and 40 years. And they do believe it's an autoimmune disease, but the exact cause isn't really known. This is from your level 2 slides too. Tinnitus, we talked about that the other day, ringing in the ears, a change in hearing. What is this word right here?
Double vision, diplopia.
We talked about dysarthria already today, that's not being able to form the sounds and the words with the muscles in your mouth. Dysphagia, what is that? Difficulty swallowing. This person can also have urinary problems depending on where the multiple sclerosis is occurring. So if this whole side of the room, if everybody in this row had multiple sclerosis, would you all have the same symptoms?
No.
It just depends on where it's occurring and how far progressed it is at the time. This is all review, y'all. This is the diagnostic. Positive plaque on an MRI is positive diagnosis of multiple sclerosis. You can have all these other things, but the diagnosis comes from an MRI. The word plaque here, what does it mean? It's places where the myelin sheath is gone. The opposite of cardiac plaque, where you have buildup, this is where it's gone. So that's what the word plaque means here.
It means absence of the myelin sheath.
So our treatment is to manage the symptoms and improve the patient's function. And we're gonna do that with all of these things down here: social services, speech therapy, they might need home health, they might need a ride to and from appointments, things like that. But there's no cure. So I'm giving supportive care and taking care of the things they need. Initially, the treatment is gonna be with immunomodulators. So you should know by now all about immunosuppressants. Do you know all about them? You should have heard of immunomodulators with your immunity stuff probably. Okay, immunomodulators are medications that are used to treat multiple sclerosis, and they are drugs that enhance the immune system and strengthen the immune system. So they're the opposite of immunosuppressants. They work with the body to get you back to normal. These are the ones that are listed in your book, immunomodulators. There are some side effects with some of them. The biggest side effect with immunomodulators is bradycardia. So what do I need to teach my patient? How to take their pulse. Because if you ask somebody, or you just tell them, I need you to take your pulse every day before you take this medication. Everybody in the world know how to do that? Nope. Lots of people will be like, I can't find it, I can't feel it. You have to teach them how to take their pulse. Bradycardia is the biggest side effect that you need to be teaching your patient about. The other side effect is progressive multifocal leukoencephalopathy. Big word. What's that mean? What's encephalopathy mean? Yeah, I have some cognition changes because of something that's going on in my brain, and this has to do with the white blood cells attacking the actual brain tissue. And it's a viral infection, and your patient can die from it. So they just need to be aware of that. You'll see it on TV. I hear it on the commercials all the time. Your patient may get PML from this drug. They just make drugs so enticing on TV. Progressive multifocal, meaning it occurs all over the brain. Leukoencephalopathy.
And did you say you're gonna have the one in parentheses on the test?
No, the parentheses is the brand name.
Right. I thought you had said that.
No.
Okay.
You're gonna see this name over here.
Okay.
Fingolimod is the one that is the most common one used. It's also the one that causes the most severe bradycardia. So we gotta teach our patients to take their The other thing about these drugs, they can help with exacerbations, but they don't slow the progression of the disease. The disease is going to progress as it progresses. So there's two or three paragraphs about immunomodulators in your book. So you just need to read about those. These are the ones assisting your immune system. Here are your medications that are immunosuppressants. Methotrexate, your corticosteroids, solumedrol, things like those. What do I need to know about immunosuppressants? Okay, my white blood cell count because I'm at a higher risk for infection. He said something about raw foods. If I'm really immunocompromised, do I really want to eat the grapes right off of the...
No, be on a neutropenic diet.
No. If I do eat raw fruit, they recommend you eat ones that have thick peel, like oranges or bananas, things like that. Should I be peeling it?
Nope.
No, someone else should be peeling it for me. What about crowns? Avoid crowns. What am I going to do as the nurse? I don't really feel good today, and I got this patient who takes methotrexate. I'm going to wear a mask, and gloves, and I'm going to wash my hands. Washing your hands is the most missed question on the NCLEX. Y'all know that? What? And when you take your comp predictor in level 4, guess which ones you miss?
Hand washing.
All the ones about hand washing are the questions that every student misses.
If hand washing is one of the answers, that's on that you.
Well, that's, okay, but that's not always right. Most of the time it is, because I'm preventing either one of two things. I'm preventing myself from getting something, or I'm preventing spreading something from one patient to the other patient. If I'm going home on these drugs, I feel pretty good.
Continue to take them.
Right, I can't stop abruptly. If I do want to get off of them eventually, I need to work with my physician and taper down the dose to get off the medications.
Are these people usually admitted in hospitals with their exacerbations? So they really?
No, they're all done outpatient. You might have a patient in the hospital for something else that has this. Who's giving solumedrol? IV push. You giving it this semester? No. I'm saying, who's giving it here? Anybody? So when I'm doing this, I'm just going to tell you the answer to this. When you reconstitute this, it is not with benzoyl alcohol. This is with sterile water. This is a dosage cal, so that is true. I believe B is true. Yes. Within 60 minutes. So if I pop this little thing and this little cork goes down here and it's all mixed together, do I have to give it within 60 minutes?
Yes.
It's good for 48 hours. Once it's reconstituted, it's good for 48 hours. So it doesn't have to be within 60 minutes. What about this, giving the medicine at 9 o'clock in the morning? Yes or no? Well, the thing about it is, if I'm starting it in the afternoon, if I'm a new patient and I'm starting it, I can give it whenever. They do usually give it in the morning because it is a corticosteroid and it makes people jittery and nuts. So do I want to give it at bedtime?
No.
No. So that's just a common sense thing, that if they're getting it once a day, it's given in the morning. Do they give this piggyback?
No. Wait.
No, they give it IV push. Ditropan, what's ditropan for? Yeah, it's for bladder spasms. So ditropan is a medicine for bladder spasms. What other things could I teach my patient about urinary control if they have incontinence or problems with urination? A schedule that I want you to empty your bladder. I want you to go sit every 2 hours and try to empty your bladder. What else? Kegel exercises. What about caffeine? Yeah, I want to avoid caffeine, alcohol. What about drinking after dinner before bedtime? No, I want to limit my fluids in the evening so I'm not up to the bathroom, disrupting my sleep. I do want to talk about this. This is a goal. I was writing a care plan on this. which one of those is most appropriate? That's a thing. Really, it's 3. C would be it. Okay, what do I need to teach a multiple sclerosis patient about stress and avoiding exacerbations? Okay, decrease stress, easier said than done. Temperature, what about it? No extreme temps. So when I get home from work, I don't want to sit in the hot tub. Feels so good. No, I want to avoid extreme temp. This is for the infections. They're usually fatigued, so get lots of rest. If you need to take rest periods, don't be embarrassed by that. Coping mechanism. That has to do with stress. People that, to be honest, people today don't have a lot of coping skills. You know, if something goes wrong, their whole life is just disrupted. I do want to talk about this real quick. Depression. Does a multiple sclerosis patient have depression?
Yes.
Yes. Suicide rates are very high in patients with multiple sclerosis. So, what's that? The shots they give them make them depressed?
No, I mean, they take a lot out of normal.
Oh, yes, they do. Yes, they do. But depression is a big issue, so you need to think about this patient with psychosocial things, and then community resources. The last part of these slides, which I'll put on the canvas for you guys when the internet comes back up. I just want you to think about these when you're studying. These are just nursing diagnoses, and most of these relate to every patient we talked about in some form or fashion. So I want you to think about these and what you're going to do to prevent these complications from occurring in your patient when you're studying. Okay? Yeah.
Are you gonna put ATI first? They had on module ones and put them on.
What do you mean they took it down? I'll go find some. ATI doesn't have good questions for level 3 and 4, but I'll see what I can find. Usually I can find some for level 3. And I'll make you a quiz. When is this test?
Next Wednesday.